Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 517 of our pharmacotherapy series, which majors in chronic kidney disease. The first case reads, PSL, a 34-year-old black woman with a 7-year history of systemic lupus erythematosus, presents to the nephrology clinic for follow-up of lupus nephritis. Blood pressure of 160 systolic, 95 diastolic. Pertinent laboratory values are as follows. Serum sodium levels of 146 milliequivalents per liter. Serum potassium levels of 4.2 milliequivalents per liter. Serum chloride levels of 100 milliequivalents per liter. A bicarbonate content of 25 milliequivalents per liter. A serum creatinine of 2 mg per deciliter. A BUN of 20 mg per deciliter. A WBC count of 9,600 per microliter. RBC indices are normal. Platelet count is 175,000 per microliter. Her 24-hour urine contains 2.3 grams of albumin. The normal value is less than 30 mg per day, and her urine analysis shows 12 RBCs per high power field. The normal value ranges between 0 and 3. Compared with her visit of a week ago, PSL's kidney function and urinary indices, proteinuria, and hematuria, show substantial worsening of her nephritis. PSL was hospitalized, and a kidney biopsy showed inflammation of 40% of the glomeruli. So my first question to you reads, what subjective and objective data in PSL are consistent with a diagnosis of lupus nephritis, and what is the stage of her nephritis? Patient PSL has clinical evidence of kidney damage as demonstrated by her proteinuria, hematuria, and a slightly increased serum creatinine concentration. Glomerular damage is most evident by the presence of RBC or red cell casts in the urine, a finding observed in patient PSL classifications. The International Society of Nephrology and the Renal Pathology Society classification system was developed in 2003 to replace the previous classification system published by the World Health Organization. This classification scheme provides a reasonable correlation among histopathology, outcome, and response to treatment. Patient PSL has proteinuria, hematuria, and inflammation of less than 50% of her glomeruli, and she is diagnosed as having class 3A, focal proliferative, glomerulonephritis. The next question reads, should PSL's lupus nephritis be treated? Unlike non-kidney manifestations of systemic lupus erythematosus, serologic markers of disease correlate poorly with lupus nephritis. Therefore, elevations in serum creatinine, hypertension, proteinuria and hematuria, as seen in patient PSL, are used as primary markers of disease activity. Treatment of lupus nephritis must address both management of the acute disease process and maintenance therapy for the more stable chronic disease process. A general consensus is that patients, such as patient PSL, who present with focal or diffuse proliferative glomerulonephritis, class 3 or 4, should be treated aggressively, with the primary goal of preventing irreversible kidney damage. The prognosis of kidney function in patients with systemic lupus erythematosus has improved. However, the prognosis is worse in blacks when compared with the white population treated for systemic lupus erythematosus. Elevated serum creatinine, heavy proteinuria, anemia, and disease onset during childhood or in those older than 60 years of age are other predictors of a worse prognosis. Advances in pharmacologic therapy, i.e., safer immunosuppressive regimens and antihypertensives, have improved the prognosis for the population as a whole. The treatment of lupus nephritis is primarily empiric, but is based, to some extent, on histologic findings. The KDIGO Clinical Practice Guideline for glomerulonephritis provides recommendations for treatment based on disease activity. Although appropriate treatment can improve patient outcomes, vigorous attempts to suppress systemic lupus erythematosus activity may lead to serious drug-related complications. The primary strategy in the treatment of lupus nephritis involves suppression of the immune system with corticosteroids and cytotoxic agents, such as cyclophosphamide, azathioprine, calcineurin inhibitor therapy, cyclosporine or tacrolimus, and mycophenolate mofetil. Clinicians need to be aware of the potential complications associated with these therapies and carefully monitor patients to determine the indication for treatment and improved prognosis. Toxicities associated with immunosuppressive agents depend on both the dose and the duration of therapy. Abnormalities in hematopoiesis, such as neutropenia and thrombocytopenia, are the most common adverse effects associated with cytotoxic agents. Immunosuppression, in general, increases a patient's susceptibility to a vast array of infections and to lymphocytic malignancies. In addition, the alkylating agent cyclophosphamide can cause nausea and vomiting, gonadal toxicity, hemorrhagic cystitis, and alopecia. The risk versus benefit of cyclophosphamide use has to be seriously weighed in young women who are considering pregnancy in the future. The antimetabolite azathioprine can cause pancreatitis and abnormalities in liver function. The selective inhibitor of inosine monophosphate dehydrogenase, mycophenolate mofetil, although relatively benign compared with the other agents, can cause gastrointestinal disturbances. Induction therapy for lupus nephritis is usually not indicated in patients with normal kidney function and proteinuria less than 1 gram, because these patients have a good prognosis. Corticosteroids represent the cornerstone of therapy in patients with a mild form of lupus nephritis. Prednisone, dosed at 1 mg per kilogram or methylprednisolone, should be initiated for patients with class 2 lupus nephritis with proteinuria greater than 3 grams per day or calcineurin inhibitor. In patients with a more severe form, that is class 3 and 4, prednisone 1 mg per kilogram per day, combined with either cyclophosphamide or mycophenolate mofetil should be initiated. For the treatment of acute exacerbations of lupus nephritis, high-dose pulse therapy with methylprednisolone may be warranted. Given that PSL's lupus nephritis has worsened, she should receive pulse methylprednisolone, dosed at 0.5 to 1 gram IV, not to exceed 1 gram, for 3 days in an attempt to reduce the degree of proteinuria and improve kidney function. Although generally well tolerated, rapid methylprednisolone injections can cause transient tremor, flushing, and altered taste sensation. To reduce the risk of adverse effects associated with the rate of injection, PSL should receive methylprednisolone for 30 minutes. After a course of pulse methylprednisolone therapy, oral prednisone at a dose 10 to 20 mg daily may be initiated. Suppression of PSL's active lupus nephritis should be demonstrated by a reduction in proteinuria and hematuria and an increase in her eGFR. The addition of cytotoxic agents is reserved for patients who do not respond to corticosteroids alone, or those who have unacceptable toxicity to corticosteroids, worsening kidney function, severe proliferative lesions, or evidence of sclerosis on kidney biopsy. Induction therapy with 6 monthly pulse doses of IV cyclophosphamide, dosed at 0.5 to 1 gram per meter squared, or 6 doses of cyclophosphamide given every 2 weeks at a dose of 0.5 gram per meter squared along with steroid therapy, was shown to have improved kidney outcomes with fewer flares and relapses. Before and for 24 hours after initiating IV cyclophosphamide, the patient must be well hydrated to prevent bladder toxicity. Alternatively, mycophenolate mofetil dosed at 2,000 to 3,000 mg per day times 6 months, or tacrolimus, dosed at 0.06 to 0.1 mg per kilogram per day, has been proven to be as effective as cyclophosphamide in the induction treatment for lupus nephritis. Given the significant toxicities associated with cyclophosphamide, e.g., gonadal toxicity and hemorrhagic cystitis, mycophenolate mofetil or tacrolimus are attractive options given their anti-inflammatory properties and the lower side effect profile. Recently, rituximab, an anti-CD20 monoclonal antibody, has demonstrated similar efficacy as mycophenolate mofetil and cyclophosphamide. I will now briefly comment on maintenance therapy. Once the acute flare resolves, generally in up to 12 weeks, low-dose, maintenance steroid therapy with 5 to 15 mg per day of prednisone can be initiated in combination with cytotoxic therapy, if indicated, based on the severity of lupus nephritis. In a meta-analysis assessing the efficacy of therapeutic agents used to treat lupus nephritis, improved outcomes, total mortality and end-stage renal disease, were associated with use of oral prednisone in combination with IV cyclophosphamide. As a result, the National Institutes of Health recommends the use of IV cyclophosphamide pulse therapy, dosed at 0.5 to 1 gram per meter squared, every 3 months for up to 2 years for maintenance therapy of lupus nephritis. An additional benefit of combination therapy with immunosuppressive agents is their steroid-sparing effect and, potentially, lower risk of steroid toxicity. Steroid and cyclophosphamide-free regimens are often desired to avoid steroid and cyclophosphamide adverse events. Studies have evaluated other immunosuppressive agents, such as azathioprine or mycophenolate mofetil, for maintenance therapy in light of the toxicities associated with cyclophosphamide or steroids. The KDIGO Clinical Practice Guideline for glomerulonephritis recommends azathioprine, dosed at 1.5 to 2.5 mg per kilogram per day, or mycophenolate mofetil dosed at 1 to 2 grams per day, and low-dose corticosteroids, that is equal to or less than 10 mg per day prednisone equivalent, for maintenance therapy. A multi-regimen trial compared maintenance therapy with azathioprine, dosed at 1 to 3 mg per day, and mycophenolate mofetil dosed at 500 to 3000 mg per day, with cyclophosphamide along with steroids after induction with cyclophosphamide in patients with severe lupus nephritis. Patients receiving azathioprine had a lower mortality rate than those treated with cyclophosphamide, and the mycophenolate mofetil treatment group had fewer relapses than the cyclophosphamide treatment group. Mycophenolate mofetil and azathioprine may be indicated in patients resistant to cyclophosphamide therapy or with a more severe type of lupus nephritis, class 3 and 4. The addition of azathioprine or mycophenolate mofetil, along with corticosteroid therapy, should be considered in patient PSL once the acute lupus flare resolves. Once suppression of patient PSL's lupus nephritis is documented, initiation of either azathioprine or mycophenolate mofetil and steroids is indicated because of the severity of her lupus nephritis, class 3. The duration of therapy is dictated by the individual's response, but typically patients will require up to 2 years of maintenance therapy. I will now briefly look at alternative agents. The KDIGO practice guidelines recommend reserving calcineurin inhibitor for those intolerant to mycophenolate mofetil or azathioprine as maintenance therapy. Rituximab, a monoclonal antibody that inhibits B-cell production, is being studied because B-cell hyperactivity is one of the major pathophysiologic mechanisms of lupus nephritis. Small studies in patients with lupus nephritis resistant to therapy have shown rituximab to be of benefit. Cyclosporine, in doses of 5 mg per kilogram per day, may also provide an alternative therapy to treat lupus in the maintenance phase in patients unresponsive to treatment. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 518.